Let's start with our lecture. This is my professional experience. I come from Milano in Italy. I teach in the University of Milano-Bicocca and Chieti Pescara, and also in an osteopathic institute. My experience in scientific area is related to sport dentistry, and in Gnathology and Orofacial pain, there are two societies in which I've been the president. At the time, I am in the board of the European Association for Sport Dentistry and in the International Academy for Innovative Dentistry. This is my professional experience with my partner, Cristian Coraini, a super strong prosthodontist and surgeon. You can see some images and pictures and movie from our education in which we give courses.
Alessandro, can you, we cannot see the presentation. Can you upload it?
Oh?
Yeah.
Sorry?
Yes.
Thank you. Something is not working perfectly at the time.
Now, yes.
Okay. Thank you.
Okay. You're welcome.
Thank you, Pablo. Thank you, Pablo Zulaika for this opportunity to show to my friends from all the world my little work. This is the picture of my personal experience in teaching. I don't repeat what I already told. And you can see here in a picture my partner, Cristian Coraini, in our clinic and our experience of teaching in our education with practical and theoretical courses. Today we speak about the parameter of a correct occlusal habilitation and how to manage the overload, because usually we need to respect the function by checking the occlusal stability over time. We need bilateral simultaneous posterior occlusal contact is important, and the disclusion in protrusive and laterality movement have to be in harmony with stomatognathic system function, with the neuromuscular function, and with the activity of the temporomandibular joint. But what is the limit for the movement? Are the teeth, and we need to check the forces on the teeth. We need to be worried about overload, and we have to managing it. The overload is have to be managed by controlling forces, because sometimes we can have problem on forces. We need to prevent to hinder the major cause. You can see here, for example, an example of restoration with an onlay in composite, and sometimes our restoration cannot prevent the fracture of the tooth. We need to check how many forces are on our tooth or on rehabilitation. Because we could have an excess of load that could create a crack on the root, and we lose our tooth, and we need to position a fixture, for example, as in this case. But also the fixture will be charged from loads. So it's not enough to have a perfect scanning as in this video of our our fixture, and only we have a static position of the arches, a static check of the occlusion, but it is not enough, because if we check the loads, we can see that, for example, the same area overloaded from the forces that damaged the root of the tooth that we extracted are also affected from lots also on the fixture and on the prosthodontic treatment. So a little grinding in the interested area can create a more balanced occlusion, more balanced managing of the forces, and we are less worried for our work and for the patient. Obviously, if the forces are strong, we can apply a system to manage them and distribute them on all the area using, for example, a splint. Why not? But here you can see in the left part of the screen an excess of load on the second molar upper right of the patient that after the little grinding is more balanced in the rest of the area. Okay, something's not going. And a clinical case. This patient is really strong. It usually is grinding, brushing his teeth during the night, but also during the day. Is stressed. People usually clench his mouth or grind. Well, he lost his feeling on a first molar. How to do to repair this molar? We can prepare for him a perfect restoration by an onlay in composite or in disilicate. In this case, it was disilicate, but I'm not. I'm worried by the situation because this patient usually overload or his mouth, or his teeth. You can see also in his face the signs of a loss of vertical dimension. Okay, only looking at the people, looking at the lips and to her smile, we can see if the situation is dangerous. Well, we have so much of information from paper and literature about how to modeling a perfect smile, a perfect restoration, a perfect only for the teeth, but it's not now. This is the scanning of the arches of the patient. I'm sorry, there is a picture that has to be opposite. You can see the static situation of the scanning. We can check, obviously, the contact of the teeth, also checking the scanning with our oral scanner, intraoral scanner. But we can see only the contacts, only the position of contacts. I have any information about the importance of this contact, about the load on each tooth I am going to checking in mouth. So it's not enough for me. It's not enough, in particular in this sort of patient, strong, stressed, and grinding. Obviously, we can record also each movement of the patient, and we can create a perfect restoration that respects the movement of the jaw, not only in opening and closing the mouth, but also in lateral-sided movements and in protrusion. We have at the time the representation of the patient in our computer, and we can model and check each moment of the contact. Here you can see by the slide cut of the teeth of the patient, but it's not enough. Bausch usually give us so much of occlusal papers of different thickness. I think it's useful also to check the patient also by occlusal papers. I usually start with 200 microns paper to check the more important precocity of contact, but is usually done. I usually use also 40 microns, at least 40 microns occlusal papers in 2 colors, because in red colors you check the movement of the teeth. So you can see the lateral disclusion and the protrusion of the jaw. And with blue colors, you do the tap that allow you to see the static contacts on the tooth. You can see here there is a difference into different occlusal paper. In this picture, you can see the check of the contact on the tooth at the first contact after the cementation of our restoration, okay, of the onlay. The onlay is disilicate, so be careful and check attentively the balance of the onlay. Well, here you can see also the red signs related to lateral movement. I have a precocity that I can see only in lateral movement. Here in red, I have not canine guidance. I have a molar guidance on my new prosthodontic treatment. So in this patient, very strong, this is dangerous. I risk a failure of my treatment. I immediately go, you can see here, with the gun, slowly, I avoid those contacts, and then you can see the final check with point of contacts in blue and any interference, any precocity in lateral movement. But the difference into the occlusal paper and to use the OccluSense is that with the occlusal paper, I can see only the final maximal interscapation. I take a picture of the occlusion, but I can't, or better, is difficult to see, to check the first contact before the movement of the jaw. And we see usually only the end of the travel of the tooth and at the maximal interscapation. So it depends on the indication. You can choose your preferred occlusal paper, but remember that occlusal paper is a quick snapshot of single moment, and only the detailed, only the check on with my OccluSense can show me each moment of the contact of the tooth. For example, for this patient, you can see a gentle contact show me only some single contact. You can see the red spikes shows me the single contacts. They are contemporary, okay, but I imagine to see in this patient so many green and yellow areas that show me that is a greening patient that have a surface of contact, not points. If I ask to the patient to strong very well, it appears also the other areas, green and yellow. Please shut up, close your microphone, please. There is something that creates a disturb. If you select an exam of 20 seconds, because you need so much of time to check the disclusion, lateral anterior movement in your with your OccluSense, with 20 seconds of time, you can check lateral precocity and anterior disclusion. And you can see that after positioning the my restoration on the patient, the only I have on the right side a perfect canine guidance. So I'm not worried about my restoration, about my only in the silicate, because this restoration is protected from the canine guidance. I didn't expect it on a grinding patient. I was expecting for a group function. No, he have also already have his canine guidance in his left side. You can see canine and premolar guidance, but it's okay. And also in anterior disclusion, I have any precocity of contact in posterior areas. So I'm happy for this situation. I don't worry about the during of my only in the mouth of the patient. Those patients usually crack our restoration and silicate. It can be also delicate. In this picture, I want to show you an idea that I got. You can use this mechanical arm to position the iPad and to see immediately the result and the report of the exam near the patient is really useful if you want to check occlusion, correct occlusion, immediately check the situation without the touch the iPad. You don't know how to put it to see immediately the result. So I suggest to buy an instrument as that is low cost and you can buy online. It's so easy to find it. And remember this simple signal that show us the different color on the report. And sorry, I come back. Okay, because in our grinding patient, people who overload the teeth, the restoration, the prosthodontic treatment, we usually see green area contacts and not only punctual contact. If you see punctual contact, you have a point of contact on your teeth and you will have so much of forces in this single point of contact. So I prefer to find areas is so easy to manage it and ensure that my forces will be distributed in a big area, so I don't risk a failure of my work and a crack. This is another interesting case, I think, to speak together, because this patient has some pain in anterior area, and he told me that sometimes, not ever, but sometimes, he feels some moving of her anterior lower teeth. Well, you can see very well in the picture, they are abraxed and grinded. And a simple intraoral X-ray shows they have a reabsorbing of the bone in the tooth, in the lower area of anterior teeth. Yes, there is a problem. There's a problem of overload. I remember that usually overload don't create parodontal problems, but resorption, with the resorption of the bone, this is possible. International literature and papers show so much of example that demonstrate that under overload we can have exposition of the cervical area of the teeth and absorbing horizontal of the bone, but any problem of infection or parodontal problems, okay, is not caused by the overload, by other problems. Well, this patient have a good lateral disclusion. You can see is good Kainan guidance, I think, and the problem is related to anterior load. Let's see how are the forces that he exercised during the movement. Well, if he closed his mouth and clench gentle the teeth, he shows me only some red points of contact that you can see in the report. Well, he have to clench very strong to show me also green and yellow areas. That means areas of overload and bruxing. These teeth anterior and the lower anterior teeth are overloaded, and sure, they have a problem of bone resorption, horizontal bone resorption, and some move of the teeth. But there is another problem that I didn't expect. The problem is related to the crossbite of the first molar on the lower right area. You can see the green, red arrows show us an important precocity of contact in the left disclusion, in which is evident that the left canine guidance is not enough to avoid a precocity of contact in the opposite counterlateral arch. So I've found a not suspected precocity caused by the crossbite. Well, this is the tooth of the patient. I don't touch it, but at the time I know over there is a precocity. It's possible this patient show me some problems of crack or grinding or headache. I will go to see if this precocity could be is a cause of those problems. And about the anterior overload, yes, when he exerts an anterior load, he exerts an important overload on the two central incisors of the lower arch. So it's a problem of dynamic movement. If you see the load in the usual intercuspation, he don't load so much because he already grinded the teeth. So they are at the time in static position, not overloaded, not so much overloaded. But in anterior movement, yes, they are. This is important to know because some patients sometimes have this evidence that create an important overload because his jaw try to stay in protrusion. Sometimes it's caused by cervical problems for cervical trauma, for example. Sometimes they have emotional problems and they try to grind forward in protrusion. So for this patient, it's more important to control and check his tendency and ability to stay forward with the jaw, so more than to control the clenching, because his clenching in usual intercuspation is not so overloading at the time the tooth. In the gentle pressure, you can see an important anterior overload because its precocity of contact is anterior. His first contact anterior. When he starts to clench, at the first contact is anterior, and then when he complete the clenching, the other contact appear in the report of the instrument. Another example of an anterior overload in a particular occlusion, because this patient have not his canine, lower left canine. She was a child when she extracted this canine. At the time, she has not. She has an important anterior overload, and we can see the teeth and the enamel is damaged from the posterior contact on the posterior area of the tooth, of the incisor. Well, we can usually apply a filling and it's easy to repair this abstraction. But I think how many times I will need to see a risk for my filling, and they can be damaged from the flexion of the tooth under overload. So I want to check the load on the tooth. Well, we can see that usually this patient that he have an orthodontic problem, obviously second class, second division for this situation that usually create an envelope, a functional envelope for the jaw and usually create anterior load. Well, in usual intercuspation, there is a surprise because you can see in the upper part of the screen on your left, we don't have overload on anterior teeth. This is interesting because is this not expected for me? When there is a load, as usual, in protrusion, or also in the right lateral sided movement. So she don't move her jaw only in left or right direction. When she moved the jaw in her right direction, she have also an anterior precocity of contact. When she moved the jaw in left lateral guidance, she have a not canine guidance. He is not a canine, but a premolar guidance on the fourth tooth of the arch. So she has not the canine, but the left lateral guidance is okay. On left side, on right side, the lateral guidance damage anterior tooth. Why? I don't know why she has this sort of movement. It depends it possibly depends from the posture, from the position of the jaw, the skull, and the neck. But I don't know. But what I know, what I am seeing in the report, it's something that creates for me prudence, and I'm worried about this situation because I'm sure the tooth are really, really loaded from the function. I would like to show you a simple system to manage the excess of load in a patient. This splint is used usually to disengage the jaw to find a new position. The patient position himself spontaneously in a comfortable position, and usually the TMJ go in perfect position. And there is another effect of this sort of splint. The effect is that with anterior load, because you can see there is a flat surface in anterior area. Well, in this position, with a load anterior in a flat surface, the elevators muscle of the jaw are inhibited. And this splint is also really useful to manage the tensive muscularidage, for example. You have to be careful because this position, if the patient don't inhibit, sometimes for emotional problem, he don't inhibit, can create pain to the TMJ. So I apply the splint only under control of the patient, frequent control for 2 or 3 months, just the time to wait safer positioning, to check the position and record it to prepare, for example, an important therapy to reorganize the occlusion. And to be sure that any tooth is damaged from this anterior position, we check the contact with this fantastic occlusal paper. I love it because it's really difficult to product, and I have to say thank you to Bausch to invented it, to product an occlusal paper that have in only 12 microns 2 colors, black and red, and a little thickness of aluminum in the middle. This is very useful. Obviously, it's not enough to use the occlusal paper. I want to check also the forces, also on the splint. Why not? This is the splint with forces, I think, well distributed. You can see on black the point of contact, and on red the movement of the patient in canine area or incisor area, because we have not the left canine of the patient. You can model it also on a CAD/CAM system if you want. It works in similar system of a COIS deprogrammer. So it's not me, the inventor. I not invented COIS deprogrammer. I only use it. But the COIS deprogrammer cannot stand in the mouth of the patient for weeks and months. So it's possible. It's better to use a splint that is stable, and the patient use it 8 or 12 hours for a day. And he will find immediately his new position. This is an example of traditional splint of disengaging with anterior contact, positioned on a traditional articulator with stone cast. And there is so much of literature that show us that this position for the teeth create an inhibition of the muscle. If you want, you can record this paper. There is, if you do a simple research on internet, you find so much of papers that show that the levels of treating of the muscle are lowest for masseter and temporal, with important difference according between the splint and the usual occlusion, or as in this paper, the splint and the splint building another system with, for example, neuromuscular position with TENS. But this is another issue. I cannot speak you about this for so much of time in this lesson. Well, and as I told, when you apply an anterior, a splint with anterior contact, be careful for the TMJ. Check the position, check the load on the TMJ, and ask frequently to the patient if all is going well at the TMJ level, because this position, similar as the night biting that someone do, can create an excess of vertical load on the TMJ. So check it. Oh, this is an important, interesting prosthetic case. I can't show you all the picture about the case because it requests pre-house. And me and my partner, Cristian Coraini, that is the fantastic prosthodontist that did this work. I helped him about the functional analysis and the check of the loads. Well, we speak about it for 3 hours in our courses. But this woman that have so much of problems, endodontic problems, parodontal problems, but also an important aesthetic need. She wants to be more beauty in his anterior area, but to have a perfect anterior smiling, you need also a perfect posterior occlusion. So we prepared for her a therapy that worked on the curves and the anterior teeth with the facet and the venous crown in posterior area, and before and then with provisional treatment in the middle. You can see the difference in contacts that are important. It is important also to check occlusion. I want to do you to remember you sorry, okay, that there is not the static occlusion, is important, also the dynamic occlusion. Both are occlusion, both are function, but the dynamic occlusion is possible, is more important than static sometimes. So the check of occlusion sometimes show us some precocity of contact. You can see here, for example, with our fantastic paper of 12 microns of thickness, a precocity in this area, just a little precocity. But this is only a static analysis, a black. With the cutter of gum, we can correct it, and it's important also to polish it and finish perfectly to avoid the crack on the tooth. And I am also really careful about the lateral guidance here on the cannon. You can check the situation is totally different before and after the correction of this little precocity. Some microns, I know, but the contacts in posterior area are totally different before and after. I have more point of contacts in on the molar and the first and second molar before this little grinding. And we can check with a shimstock paper of 8 micron thickness to check and control if the tooth are in perfect contact. But it is not enough. obviously, after the check of the occlusion with occlusal paper, we want to check it also with the OccluSense to check the forces. We can do a check of the maximal intercuspation and a check also of the moving, anterior and lateral movement. 20 seconds of time is possible. You need less time than 20 seconds, but with 20 seconds, all the people can move and roll. Look at the papers after the check. It's interesting because you never find a hole in the paper. And you can see also the aluminum in the contact areas. Well, it's useful to check the occlusion in all the arch, to check if we have precocity of contact. You can see on the left side a premolar guidance, a group guidance, and a difference between contacts with 12 microns occlusal papers and 200 microns occlusal paper. Is different. It's possible I see so much of contact with if I use only 200 microns occlusal paper. But those contacts, is possible they are not real, because if I use the thin paper, I know the difference is with a paper of 40 microns. 40 microns show me too much of contacts, because, for example, this contact that I can see with 40 microns don't exist with 12 microns of thickness. So be careful. It's possible you see something that is not. This is my precocity that I greened in the last picture. After this precocity, the contacts are perfect in the posterior area. Before, the patient cannot to get the 8 microns paper, the shin stock. Well, greening this, and posteriorly upper contact. Obviously, moving on the red area and clenching on the black or blue color. And then, well, what about the OccluSense analysis? You can see it's easy to see that the precocity of contact on the first premolar that I suspected with the card is absolutely confirmed and shown by the analysis with OccluSense. You can see the red spike really evident on this tooth. And this precocity could be not so important, but is important, because I don't want to damage the patient. I don't want the patient to change his movement to avoid contact, or don't change his moving and load the restoration and correct damage and the next instances of my restoration. In the lateral side in moving, you can see also a precocity in the opposite side. This is really dangerous for the function and for the work. And this is the situation before and after the greening. This patient is an interesting case that I show also in the basic level, but I want to show this case also for you, because it's not frequent that happens an important trauma in the anterior area. This patient have a double trauma, anterior trauma that move anterior teeth in the palatal side, and then a second trauma under the thin that moved again the teeth in vestibular position. Two movements. Has been a terrible damage by bicycle. So it was with bicycle with his son. Nothing of important competition, daily activity. Well, after the major, I'm sorry for the picture because I was lonely in my clinic with the photographic machine and the patient. It was a Saturday at 8 hours in the PM. So something we have to do. Well, obviously in the weeks we had to do
Wanneer? Moet je zo'n duim tempo strooien, pode? Moet je zo'n duim?
There is a question. If you have not a question, please turn off the microphone, and you can put in position the questions on the chat.
Vladimira, could you please switch off your microphone, please? Thank you very much. Vladimira.
Pardon. Anna. Yes, of course.
Thank you, Vladimira. Well, we did an endodontic treatment. We splinted with elastic system the teeth, but also we have to check the load on the teeth. Well, the patient at the time is in a good health. He asked us to have orthodontic treatment because there is a little difference of position of the lateral incisors, but we are worried about the contacts. Well, about the static occlusion, we are not so worried because the contacts are in maximal intercostation are well balanced. Oh, we have a precocity of contact on the wisdom teeth tooth upper right. This is indication to extract the tooth or to grind it. But if you grind it, the tooth will be found a new precocity in some weeks or some months. But it's important why I tell you to check dynamic movement. In dynamic movement, we have an important excess of load on exactly on the two damaged teeth. In lateral movement and anterior movement, you can see it's easy to see an excess of load just on the lateral upper right tooth, the lateral tooth that he risked to lose it. So why not to do orthodontic treatment to this patient? Is important because I want you gain more vertical dimension, and I want to avoid the precocity of contact and the overload on the anterior teeth. So why not? Immediately, we are starting with his orthodontic treatment. And now I show you another prosthodontic case. This patient is really strong. It's an old man, 60 years old, but his life is really active and is a grinding person. This case has been managed with my super partner, Cristian Coraini. You can see the situation of the tooth and also all the restoration of prosthodontic treatment and an occlusion that is not balanced. Well, I cannot to show you all the part of the treatment because it requires so much of time, but I can assure you that we have got maximal attention in increasing vertical dimension and in balancing also the occlusion on the provisional treatment and then on the final treatment. You can see here a cross-mounting of the models to be sure to respect the position of the jaw on the cast and on the articulator. And immediately we go to the final restoration. This is the final work made and applied by my partner, Cristian Coraini. My work is to balance it and check overloads. Well, this work is good for an old person. This patient don't want an aesthetic like a young people. He wants to be natural. And the technician had to work so much to create some natural teeth for this patient. What about the control of the occlusion, or the stability of the occlusion? Let's go immediately. Well, in the 2000, when we positioned the work here, you can see the work were perfectly balanced. Not perfectly, because on the second molar upper left, you can see we've got a precocity of contact in lateral left movement, but we found it and grinded it. Yeah, I don't know if you know what is a Brooks checker. A little and thin splint in red color. The patient have to wear it during the night, one night, then he send it to us. We can take a picture on a white surface. We can check what the patient do during the night, if we grind on the teeth, and if we have some precocity of contact that we cannot to see in our clinic. Well, you can see the same precocity on the second molar, the same precocity in the lateral movement that we had to correct. Well, after so much of year, the patient come back in the clinic. Well, he usually come back to oral hygiene and the controls, but the years pass, years and years, and 2 years ago, he come in the clinic and he thought, there is something that is not perfect in my anterior area. Yes, it's true. We have problem of grinding of the anterior area. You can see they are damaged, and we had to repair them with fillings. So erosions after 9 years, erosions in anterior areas and also in the interior areas, not only on the vestibular side, but also in the palatal side. And we suspect these erosions are created by an excess of load. In the opposite tooth, in the upper jaw, the incisors show some area of chipping of the ceramics. So we are sure there is an excess of load in anterior area. So it's a grinding patient. We repeat the Brooks checker. You can see how to produce a Brooks checker. It's simple and not expensive. And we check the checker with the patient. And the contacts are, after 9 years, totally different. The patient have an assessment of the jaw. He's in comfort, he have no problem, but they are not the same contacts. We have to balance it. And let's check the occlusion with the OccluSense. It's important for us to check occlusion with OccluSense because I need to quantify the loads. And also I need to find the precocity of contacts. Without the OccluSense, I only can see the final situation after the moving of the jaw in assessing the position during the clenching. But I need to see the precocity. Well, you can see that, for example, the upper first molar on the right side, I have an important precocity. And also in the left side, I have precocity. The same precocity that created problems 9 years ago. Well, but important immediately to correct this precocity. Okay. By grinding the surface of the tooth. And also we can see an excess of load in the anterior area, and the incisors need a needle balancing by a gentle grinding to avoid excess of load that can damage another time the ceramic restoration. Well, on the left sided movement, we can see a perfect canning guidance. On the right sided movement, we have a group guidance. Okay, it's okay. Oh, it's possible I prefer in this patient, but I don't want an interference in precocity in right movement on the last molar. And remember that usually the protocol is to check the existence of precocity with the OccluSense, then you can balance the occlusion using the occlusal paper as you want, but I prefer to check with a high thickness paper in the first part of my check, and then I use more thin papers until to 12 microns, okay? And in the final part of the check, we check occlusion after the balancing with the paper to control if all the logs are correct. And this is perfect to reserve and take your documentation for the years successive and to check the situation during all the life of the patient. I want to answer to your question, so I stop my presentation and I go to see if we have some question on the chat. Oh no, there are no questions. If you have some question, I would like to answer you. I would be honored to do it. And thank you for your attention. Thank you also to Bausch and Pablo Zulaika. Well, not perfect. Thank you for your attention. So there is some question. Pablo?
Yes, Alessandro, you have to check them on the chat. You have some comments.
I'm checking on the chat. I don't see question at the time.
Yes,
oh,
there is.
No, I checked for some question. Okay.
Yes.
Oh, thank you for the congratulations from Brazil and Mina. Hello, Mina. How are you? Oh, what I used to define the new DVO. Okay. Hard question, but we can speak about the vertical dimension. Alexander is an important question. I think that, as you can see in literature, we can change the vertical dimension of about 2 millimeters. There is an important paper from Mauro Fradiani, Italian, that demonstrated we can change vertical dimension of about 2 millimeters without to be too much worried for the patient, because the patient have usually an adaptation. But I am a gnathologist. My patient usually don't adapt to the new situation. My patient have so much of problem of the adaptation, because it's possible they exhausted the ability to adapt themselves to the new position. So I usually check it with electromyography, with the OccluSense, and I ask help from the physio or from the osteopath of the patient. We prepare a simulation of the new position with a splint. The patient can use the splint for some mouse to check the position if the patient feel comfortable situation. So we can use this position to create a new project for the patient. How to change the position? Well, it's simple for me, because I asked my technician, for example, is one possible. The patient has no symptoms. I'm not worried for his head. but he need increasing of vertical dimension because he have a grinding teeth, and he need to do a restoration, a prosthodontic treatment, for example. I need more space. So I asked to my technician, how many space you need? He told me, well, I need 2 or 3 millimeters. 2, 3 millimeters. Well, check on the patient with electromyography. If the patient like a new position, we check the temporomandibular joint movement, and we look if the position of the rotating point of the TMJ is displaced too much tall in the fossa or too much forward, for example. So I know the patient is moving, the jaw is moving. I'm so happy to do a new good position for the TMJ because so much of space needs so much of protection. But usually the problem of TMJ don't come from a problem of vertical dimension. I think they are more related to the lateral movement on the plane. So it's more dangerous a problem of displacement of the jaw on the plane that about vertical dimension. Is because so much of people lost his vertical dimension but lives in perfect health. And then we check the situation, the emotional situation of the patient, because there is some patient that is really stressed on anxious or so much of other problems for ideal for psychologists. And those patients are a really important problem because they have frequently an excess of sensitivity. So we check, it's important to check the position with the splint, because the splint is a therapy that can be cancelled. You can check your splint, and if the splint is not tolerated from the patient, you can move out it from the mouth and try another position. I don't think there is a theory that can give us the perfect position for the jaw. There are so much of position correct for the patient. We only have to respect the function to stand into the tolerated position from the patient. If the position, but the ability to tolerate is different in each patient. The use of OccluSense allow me to check the loads and to check, for example, if the occlusion is too much artificial or is well balanced and comfortable. I don't, in my lessons, when I speak about occlusion for my students of the university, I don't usually speak about malocclusion, bad occlusion. What means bad occlusion? I need the occlusion integrated in a correct position that is comfortable, respecting the position of the jaw, that have to rotate and translate as it wants and not as I want. We have to respect the needs of the TNJ that don't adaptate too much. We had to listen the muscle to record the activity, to check if the muscle like the new position. And then we have to check the occlusion to check if the loads are perfectly balanced, because an excess of load creates problems. For my work, is possible. Pain, muscular pain is possible. It's not so much possible about pathology of TNJ. There is not so much of literature that show this. But there is also a problem of sensitivity of periodontal tissues. An excess of load can create adapted position of the jaw that move itself in a position adapted to avoid the pain for the teeth, for example. So in effect, the use of OccluSense create for me the ability to avoid the adaptation of the jaw. I don't want the patient is adapted to my work. I want to adapt the work to the patient. Oh, okay. And Raphael, tell me, can you tell us with more detail how difficult is to use the OccluSense? Oh, I don't think it's difficult. I show how to use the OccluSense in the basic lesson, in which I show step by step how to use it. But usually you can use the OccluSense as an occlusal paper. But as I tell to the patient, the OccluSense is an improved occlusal paper that don't show me only the position of the contact, because the sensor also can give some point on the teeth. But it's important that I check also the load, the forces. So to manage the forces, I need to position this sensor. But it's really, really easy. Only to select the patient on your tablet, press start and clench, or select select the program you want to use for dynamic, for example, movement, press start and ask the patient with a paper to move right on left or anterior position the jaw. So it's really, really simple. If you want, I think we can prepare a basic lesson in English. Pablo, if you think it's useful, we can prepare a basic lesson. It's possible someone see the OccluSense for the first time in this lesson, and so it's possible someone needs a basic lesson in English, we can prepare it. And Antonio, ciao. Far serrare al massimo durante il primo rilievo OccluSense. A colleague from Italy asked me, is possible to join the maximal clench during the check with OccluSense? Yes, you have to join the maximal clench, because it's the maximal clench that show the maximal point of contact in your, is named maximal intercuspation. The maximal intercuspation is the position in which I have the maximal point of contact. But in the first time of the contact, because during the check of the report of the OccluSense, you can see the milliseconds. How to say milliseconds? Millisecondi. You can see slowly, really slowly, the contacts during the clenching. So you can see really the precocity of the contact, the first, the second contact, the third contact, in just a little time, half of a second, you can see all the contacts that appear in the report. Sometimes I try to check it without avoiding an excess of pressure to be sure to see the precocity. But you can see the precocity also if you clench in maximal intercuspation, if you check the first part of the stem during the video, because you have a video of the clench. You don't have a picture. So you can see time by time, step by step, first, second, third, fourth, until to the last contact. It is interesting also to see at the end of the clench, when the mouth is opening, which is the last contact that give the sign so on the report. Quindi contestualmente sì, fai premere forte, ecco, però ci sono delle volte in cui già guardando nei primi millisecondi tu vedi comunque i primi momenti dell'esame. Delle volte mi piace fare premere più delicatamente per capire dove il paziente va, proprio nei primi momenti di contatto. Ok, Dr. Solang, tell me, will be the OccluSense findings in case of a patient with a straight teeth comparing to the one with normal teeth without any attrition? Ooh, yes. Yes. If I can share my screen, I show you the slide that I've shown. There is a big difference. And I provide to show you a little trick.
Alessandro?
See?
Yes, just remember that Mina is doing a really, really wonderful webinar introduction in English also for yes.
Perfect.
Yes.
Can you show the date of this webinar in English?
It's you can book it in our website in the OccluSense.com in the webinar area, and she's doing it every 2 weeks in English. So it's just for Dr. Ruvi. He can join the next one if he would like. It's a really, really nice one. Okay.
Right. And thank you, Mina. And don't lose the webinar of Mina. Is a fantastic professional. I see her her work, and I will see myself the webinar. Thank you.
Yeah. Cheers.
Close the webinar.
Yes.
Well, in this patient, I've shown you that when the patient clench strong, appears the green areas. There is a difference between a patient who show me only red spikes and the patient who show me red spikes, but also more areas, green and yellow, as that. What mean the colors of the OccluSense? Means that if I see only punctual contact and red spikes, I have a patient who has only points of contacts. So I have all the force, all the load in a single punctual contact. This could be dangerous for the resistance of my prosthodontic treatment, of my ceramic treatment, for example, and I need, in this case, so much of punctual contact because I need the load is distributed on so much of punctual contact. If I see red spikes, but also yellow and green spikes on the surface of the occlusion, I am sure that I see a patient who has grinded his teeth. Grinded is grinding at the time or grinded in the past. I can know if he have got in the past emotional problems at the time his life is happy, he don't grind no more. But if you see important area of contact with green and yellow area, you can be sure that this patient is a bruxist. Yes, really, this is the difference in the report. Some, oops. Che è successo? Sorry. I'm online, yes. Just for static occlusion, how my time shall we record? Oh, the instrument is set on 40 seconds, 4 seconds. And 4 seconds are enough. But you know, some people, when you tell them, close your mouth, you look at the sky, then you think at his family, and then close. So it's possible sometimes you need to give the patient some more time. But usually the 4 seconds set on the instrument are enough to check the static occlusion. So it's important you have some dental assistant that prepare it for you. You don't have to lose your time to prepare the instrument. You have to be immediately ready for you. And when the patient need to check the occlusion, you are ready. So you check with the occlusal paper, and then immediately someone give you the instrument. Give me, please. Tack, check, control. Don't have to lose time. It's really fast to check the occlusion with OccluSense, but it have to be immediately ready inside of you, see, in your side. If the instrument is not immediately available, you have to wait. It's possible you don't use. So immediately ready on the back of your operative area. Okay. 4 seconds. Okay, I don't think there are other questions. I don't see other question. So I can say you goodbye, and I can tell you thank you for your attention. I don't know what is the time in your country, but it's possible someone is not comfortable in this time. And I'm honored for your interest and glad to show something to the colleagues of all the world, and glad for the friendship with Pablo Zulaika, with Nina Knazemi, and also to work with Bausch. For me is an honor. So thank you for your attention. and see you soon, I hope.